Next, we have Dr. Mohamad Jahanzeb will be speaking with us about treatment of patients that we all still see, those with metastatic breast cancer. Dr. MJ?
Thank you so much, and especially for being one of those rare individuals who can pronounce my name. I was recently called Jahanzeb, and in this day and age of small molecule tyrosine kinase inhibitors, I thought I should patent it before a company takes it. Yeah, if you can please pull that up.
Sure. Do you have...
But I have the distinction of traveling the furthest for this conference, and credit goes to, again, my friend Dr. Binaytara. Due to my long association with him, I could not say no. I said, I'll definitely come. So he's a special man. As you can see, he puts in a lot of effort into putting this together. So thank you for having me. So after I committed to this topic, I suddenly realized that I had committed to too broad a topic for the time frame. So I have cut a lot of my slides. I still have too many slides, so I'll talk as fast as I can while remaining intelligible, which is not easy with my accent. So I may go over a couple of minutes over my time. So as we all know, breast cancer is a group of diseases that we at least treat as 4 different diseases. And I say 4 because 2 of the circles overlap, creating a 4th entity, i.e. patients who are triple positive, who have hormone receptors positive as well as HER2 positive disease. So while 2/3 of the patients are hormone receptor positive, only about half of HER2 positive patients are hormone receptor positive due to the reciprocal downregulation of the hormonal axis with HER2 positivity. And then there are, of course, the patients who are triple negative. That's considered a separate entity, as if we suddenly discovered a new disease a few years ago. They have always existed. We just never called them that. So, and now we know that there are subcategories of that. So previously, our considerations when we saw a patient with metastatic disease were to parse them out by receptors, see what previous therapies they had gotten, what response they had, what was the disease burden, what was the tempo of the disease, and if somebody had a lot of disease burden and they were young and the disease was progressing rapidly, we quickly recognized that you will not get a second chance to make a first impression on this tumor, so we use combination chemotherapy. Otherwise, all other patients get sequential single-agent therapy. That's the paradigm in breast cancer. But going forward, now we have next-generation sequencing that we think of to look at the genetic makeup as to what is the driver gene for this particular tumor. And beyond genetic structure, there's, of course, the protein expression dictated by genes, which can be altered. The message can be altered in between. Those are called epigenetic changes. And we can study coding RNAs to see if those have occurred. And now there's a whole new field of immunotherapy. All of this is evolving as we speak. And a lot of it is not ready for prime time, but that's where the future is headed beyond just these 4 buckets of metastatic breast cancer parsed out by surface receptors. I must say, being a physician who does both lung and breast cancers, that certainly lung cancer has leapfrogged way ahead of breast cancer in terms of molecularly targeted therapies. But in breast cancer, bulk of decision-making is still based on receptor type. So my talk is divided by receptor type. First, I'll talk about HER2 positive disease, where we have made the most rapid progress in the last 2 decades. As you can see, the milestones, starting with the discovery of EGFR family. There are 4 members of the family, alternatively called HER2 or EGFR, epidermal growth factor receptor, or human epidermal receptor family, which is the same as ERB2, by the way, which recently I've been teaching insurance companies. When they say, you said HER2, but this is ERB2, I tell them it's the same receptor. In mouse, it's ERB2. In humans, it's HER2, hence the H. Then they feel embarrassed, but they're pediatricians and radiologists. So in any case, so Herceptin or Trastuzumab got approved in 1998, so it's not even been 20 years. And then there's been a flurry of activity ever since for additional targets, and our options have expanded. we not only know that HER2 blockade is important, we now know that continued blockade is important. We know dual blockade is better than single blockade. We have introduced heterodimerization inhibitors, antibody toxin conjugates, downstream pathway inhibitors, and then we have small molecules that are pan-HER inhibitors, such as neratinib on the horizon. And then there's a whole class of compounds, such as cell cycle inhibitors, heat shock protein inhibitors, vaccines, bispecific antibodies. So I won't have time to talk about all of these, but we'll go through the journey systemically. After Dennis Lehman established that trastuzumab was important and gave 5 extra months of survival when added to chemotherapy, the next step was to know what to do next. And we didn't have any other drugs, so everybody continued trastuzumab and kept changing the chemotherapy in second, third, fourth line setting without any proof. Ultimately, Europeans, Gunther von Minkwitz, showed that if you randomly assign patients to continue or stop Herceptin when adding capecitabine in the second setting, that continuation of trastuzumab is important and causes longer progression-free survival. That's the study on the top. Chuck Geyer, the second study, was actually with the second new HER2 blocking compound, which was a small molecule tyrosine kinase inhibitor, lapatinib, showed that after trastuzumab failure, lapatinib can be better than capecitabine alone. So lapatinib plus capecitabine was superior to capecitabine alone and led to FDA approval. And finally, Kim Blackwell and Joyce O'Shaughnessy showed that when patients become refractory to trastuzumab, you can switch them to lapatinib, or you can continue trastuzumab and add lapatinib to it while they had just become refractory to trastuzumab, and that dual blockade is still superior to lapatinib alone. So now we know from systematically done clinical trials these facts, that continued blockade is important and dual blockade is better than single blockade. And then whenever we have 2 pennies to rub together in oncology, we compare them. So the question was, is lapatinib better? Is trastuzumab better? So Canadian investigators did the study using paclitaxel as the chemo, or actually they gave the choice to investigator to use whichever taxane, and randomization was to lapatinib and trastuzumab. That showed that trastuzumab is superior in terms of PFS. Another trial mainly done to study the brain metastases and using the theory that small molecules will penetrate through the blood-brain barrier, and lapatinib is a superior drug to prevent brain metastases or even treat them, randomly assigned patients to lapatinib or trastuzumab. While there was not much difference in brain metastases, it was 3 versus 5%, the trial had to be stopped after 440 patients instead of the 600 they had planned, because progression-free survival was a lot inferior with lapatinib. So that theory of using lapatinib as a superior agent to protect the brain has gone out the window. What about hormonal therapy? So when patients have triple positive disease, you always used to wonder what to do. Should you give them just hormonal therapy initially? Should you combine both together? So on this slide, I actually show you 4 studies. On the top, you see single-agent trastuzumab response rate shown by my colleague Chuck Vogel, who still is my colleague in Florida, that it's about 26% response rate. At the bottom is Henry Gomez from Peru, who has the largest ECOG center outside United States, who showed that with lapatinib, you get about 24% response rate, first-line single-agent metastatic setting. In the middle are 2 randomized trials, comparing hormonal therapy alone to hormonal therapy plus HER2 blockade, either trastuzumab in one study and letrozole in the other study. This actually led to letrozole's approval with lapatinib in the United States. And you can see that in both of those trials, single-agent hormonal therapy, hormonal therapy, when added to trastuzumab, produced response rates that are no superior to what you see on top and bottom. And the progression-free survival was very short with hormonal therapy alone, telling us that patients who are triple positive using hormonal therapy alone is largely a waste of time. You're not really adding much by adding that or using that alone. So unless you have a patient who has very minimal tumor burden, 1 or 2 bony metastatic foci, and not symptomatic, generally it's not wise to dilly-dally around with hormonal therapy in these patients. They need HER2 blockade with chemotherapy. Then came the era of novel antibodies after trastuzumab and lapatinib, and the first was Pertuzumab, which actually, when tested alone, turned out to be inactive. And the program was about to be shelved when some people made the observation that it only works when added to trastuzumab. So there's no role for Pertuzumab single agent in breast cancer that's HER2 positive without the use of trastuzumab with it. So Pertuzumab acts on domain 4 and prevents the dimerization. 2 family members have to come together, dimerize, to start signaling downstream. So it can be heterodimerization, and most potent heterodimer is HER2 with HER3, or it could be homodimerization of 2 HER2 receptors. And Supreme Court has recently ruled that both kinds of dimerization is okay. So I would call Pertuzumab a molecular chastity belt that doesn't let that dimerization happen, and that's how it works. So to test that in a large phase 3 trial was the pivotal Cleopatra trial after initial clinical work that looked at the standard docetaxel trastuzumab regimen as the control arm with placebo to prevent bias versus Pertuzumab added to trastuzumab with docetaxel. And the results were very impressive. Not only was a 6-month improvement seen in progression-free survival, we saw a huge improvement in overall survival. We had never seen overall survival approaching 5 years in metastatic disease. So 56 months overall survival with the triplet in this setting was quite mind-boggling. TDM1 was the other antibody, but this is actually an antibody-drug conjugate. It's a chemoimmunoconjugate where they took maytansine, a spindle poison that had been shelved in the 70s as being too toxic, and found a stable linker where the drug would not break away from the trastuzumab particle in circulation. And trastuzumab particle, like a vehicle, a smart bomb, will take it to the target, to HER2, where the chemo particle would be internalized into the cell and cause cytotoxicity. So it's the stability of the linker which was the discovery here. The other 2 parts that were being joined were already around, one for 40 years. So pivotal trial, again, I don't have time to show you previous trials, but a previous trial, phase 2 randomized, had shown that docetaxel trastuzumab are inferior in efficacy and toxicity to single-agent TDM1. Edith Perez had presented that, and Sarah Hurwitz published it. But this pivotal trial called Emilia, and most of these trials are named after ladies, as breast cancer is a woman's disease, and they spent sometimes more time coming up with the name than the design of the trial. But this Emilia study compared the standard second-line capecitabine lapatinib to single-agent TDM1, and by both independent review committee and investigator review, the results were overlapping with a 1/3 reduction in hazard of progression. And here's the overall survival, showing a 5-month survival advantage. So remember, Dennis Lehman had shown improvement from 20 months to 25 months in first-line metastatic HER2-positive disease by addition of trastuzumab. Here's second-line. These patients have progressed after trastuzumab, and we see still a 5-month improvement in survival, and at a higher level from 25 to 30. Then came the third-line testing in Teresa, and this is pretty clever, as I learned when I got to Moscow, that this is how they write E in Russian, is a 3. So this is actually a Teresa, if you read that 3 as an E, which gave the choice of therapy to investigators for the control arm. So that was physician's choice treatment, and TDM1 was compared to that and showed that it had a PFS advantage. Survival has not matured yet, but in the 2 curves, the upper one and the lower one, you see patients who did not or did have trastuzumab upon progression. And that led to, this whole development led to the idea that if trastuzumab docetaxel is inferior to TDM1 alone, could we not come up with either TDM1 alone as the first-line standard therapy or even improve it by adding Pertuzumab to it? So Pertuzumab was, again, added because Trastuzumab is already part of TDM1. You get about 1/5 of the dose of Trastuzumab if you give TDM1 by weight. So that design was very logical, but the results shown below that were somewhat disappointing. It was a completely negative study. And whenever we have a negative study, we do a lot of head scratching as to how could that happen. Something's wrong here. We don't accept negative results easily. And then one has to think that this population of HER2 positive patients is actually a mixed population these days. We have de novo metastatic patients. We have patients who have had trastuzumab in the adjuvant setting and progressed quickly, relapsed quickly, and those who did not relapse so quickly. These are three different groups of people that have different level of refractoriness or sensitivity to trastuzumab. So when you look at these large randomized trials side by side, at the bottom you see that MARIANNE had the most patients of any other trial because it was the most recent trial, and trastuzumab is pretty much the standard of care. Sorry. What happened to that slide in between here? So 31% instead of the 10, 11, 18% in the other studies. So there was a letter in the New England Journal of Medicine which raised the point that the results of these trials are relevant today only for de novo patients, not necessarily what we currently treat. And Sandra Swain responded to that letter by doing an analysis of Cleopatra, which was the study she had published, and showed that the difference in the small group of patients that had previously been exposed to trastuzumab was indeed somewhat smaller in both regards. Overall survival was not up to 56 point some months, but 53.8 months. And p-value was not reported because it obviously would not have been significant due to only 88 patients, 44 on each side. So we do know that there's a difference, and maybe that's why MARIANNE was negative. But we have to keep these things in mind when clinically making decision on a patient who's HER2 positive metastatic as to which category do they belong. Hence, the buzz term of personalized, individualized medicine. So beyond trastuzumab, beyond the surface receptors, there's additional signaling going on within the cell, and a central relay station here is mammalian target of rapamycin, mTOR, which can be inhibited by drugs such as everolimus. So everolimus has been used in 2 trials in HER2 positive patients, and we all know about BOLERO-2, which was in hormone receptor positive patients, but I'll come to that later. BOLERO-1 and BOLERO-3 were in the first and third line setting for HER2 positive metastatic disease, and BOLERO-1 involved paclitaxel, and BOLERO-3 involved vinorelbine. Both have been presented. BOLERO-1 was at last San Antonio meeting, presented by Sarah Hurwitz. And the interesting thing was that this trial seemed to show a 7-month improvement in PFS by adding everolimus to treatment with paclitaxel, and seemed to reach statistical significance, but was not because of the p-value that was previously agreed upon. It fell short of that. Hormone receptor negative patients seemed to fare better in this study, and they were the only subset that derived benefit. And the reason probably was that if you have a hormone receptor positive patient but don't give hormonal therapy, then by blocking the HER2 axis, you are promoting signaling through the hormonal axis, which becomes active, and that was not blocked. So maybe the answer was to only do this experiment in ER-negative patients, and that's what's happening as the sequel to this study. That's where we stand on this approach here. BOLERO-3 had been reported by Ruth O'Regan previously and was positive, statistically significant, but the advantage was only 1 month. So one was clinically meaningful difference of 7 months, statistically negative. The other was statistically positive, but clinically not meaningful, 1 month advantage. So this approach remains experimental. But at this ASCO, what Dennis Lehman did was got samples from both studies and did molecular analysis, next generation sequencing, Sanger sequencing, and immunohistochemistry for PTEN to see if we can tease out a subgroup of patients that may benefit from everolimus or such drugs. So his analysis was interesting. He color-coded the data by BOLERO-1 in orange and BOLERO-3 in green, and he compared it to the Cancer Genome Atlas data in blue. So first of all, you see that there's roughly good concordance that their testing worked. They only for c-MYC, it looked like there were differences in the height of bars. The other interesting point was that only about 80% of patients on molecular sequencing were HER2 positive, so our tests are not perfect. So these were all FISH-tested patients, but some were not HER2 positive. Similarly, there were minor discordances, and P53, PIK3CA were very common mutations. Otherwise, most mutations are in single digits. So diseases that we have been considering very common cancers are actually large groups of rare cancers. So that's another lesson to learn. That's why we are much more successful in treating uncommon cancers like hairy cell leukemia or CML. You know, I used to teach fellows that it's not that Gleevec is a great drug, it's just that CML is a woefully simple disease. So here we have very complex diseases which we try to treat similarly, but they don't respond that way because of being so heterogeneous. So we have to keep chipping away at the truth about these tumors to divide it up into smaller and smaller groups of rare diseases. So what he saw was that when you look at PIK3CA genotypes, those patients seem to benefit from addition of everolimus. Patients who had PTEN loss, they seem to benefit from everolimus, and FGFR pathway did not seem to matter, at least we don't know how to target it yet. So now this is a small selection of groups of drugs, about a dozen groups of drugs that are currently being tested. For example, I list only one vaccine, but there's like 7 vaccines in clinical trials in HER2 positive disease. So this bodes well for our patients, that so much research is going on and the outcome of our patients is going to improve. Until then, this is what we do in the clinic. When we go back on Monday, we still look at a patient and see if they have very low burden of disease, no symptoms only, then we do the letrozole, lapatinib type approach, or anastrozole, trastuzumab type of approach. All others get funneled into this pathway of chemotherapy and HER2 blockade, and the preferred recommendation by NCCN is to do dual blockade, the Cleopatra approach. You don't have to torture patients with docetaxel. Weekly paclitaxel is permitted and in the guideline, so nobody should hopefully get docetaxel at 75 milligrams. If not, if there are payment issues, complication issues, availability issues, then trastuzumab with chemotherapy is okay. Note that it's plus minus chemotherapy, so trastuzumab is a must, chemotherapy is not, but we usually employ chemotherapy. Second line, unanimous TDM1 preferred, and beyond TDM1, there's a whole host of options ranging from capecitabine, lapatinib, or giving trastuzumab with a different chemo, or avoiding chemo and combining lapatinib with trastuzumab. All of those options are valid. So with these approaches over the years, it's very encouraging that Slayman showed a 25-month overall survival compared to 20 months with chemo, and it had been consistently going up, and now we are up to 56 months, approaching 5 years in the first-line setting. In the second-line setting, we have gone similarly up to 30 months now, and even in the third-line setting, we have broken 1 year. So this is very, very encouraging. These are small incremental gains, but one has to remember that this is the averages. There are highly above average patients who do amazingly well. My biggest success story is a patient who's alive 16 years into her metastatic HER2 positive breast cancer with liver metastases that were biopsy proven in 1998 or 99. So she's now 6 years out from therapy. I'm still not allowed to use the C word. I can't tell her she's cured because we are not allowed to do that for metastatic disease, but she probably is cured just with systemic therapy. So in summary, HER2 positive patients now have an expanding menu of options for their treatment. Continued HER2 blockade beyond progression is important. Dual blockade is better than single blockade. And multitude of novel agents are being tested we really have to keep studying the mechanisms of resistance. Okay, that was the longest part of my talk because that's where most has happened. So I'll go a little quicker now. So hormone receptor positive disease, you all know that we have had multiple approaches to hormonal therapy, and unlike prostate cancer, where we used to believe that once you fail first-line hormonal therapy, you're pretty much done, we have always been able to treat breast cancer with multiple lines of hormonal therapy. And my colleague and I would also consider my mentor in breast cancer, Chuck Vogel, was a big hormonal therapy guy, and he used to take pride in the fact that he has gone to 8th line and 9th line of hormonal manipulation in patients, because he would even use tamoxifen withdrawal as manipulation, which has 15% response rate. Because really, hormone receptor positive breast cancer cells are like fish, saltwater fish. You can increase the salt, you can decrease the salt and kill them either way. So you just have to manipulate and perturb the hormonal milieu. It doesn't matter. You can cause estrogen deprivation with the aromatase inhibitors and kill them, or you can give them estrogen, DES, and kill them. So that's important to remember. It's just the change, fluctuation that matters. So the pathways and guidelines have diverged according to menopausal status, because we cannot give aromatase inhibitors to premenopausal women. That would put their ovaries in overdrive by sensing estrogen deprivation and pour more estrogen into the system. Other than that, the guidelines are fairly similar, so the consideration in a premenopausal woman has to be given to oophorectomy. And there are some colleagues of mine, including some who are at an ASCO panel, a hormone panel with me, who all believe that every premenopausal woman who's ER positive should have an oophorectomy from the get-go. I think that's a bit extreme, but that's something to keep in mind. Because why leave an organ that makes estrogen in the body of a patient who has an estrogen-positive tumor with metastatic disease? So there are many options. The real question was, can we do it better? And previously, all we had was tamoxifen with the new advent of aromatase inhibitors in the 90s. When you put those two together, it's counterproductive, because aromatase inhibitors in postmenopausal women create near zero estrogen state. In a near zero estrogen state, tamoxifen acts as a weak estrogen and robs the advantage of the aromatase inhibitor. That's why the combination arm of the ATAC trial was closed. So we don't do that. However, we got the next tool, which was fulvestrant or Faslodex, and it was natural to try to combine that or to compare that. So these are two combination trials of fulvestrant with anastrozole. One was negative. Southwest Oncology trial was positive, even for a survival advantage. And you can look at the reasons very clearly when you put them side by side, that in the Southwest Oncology group trial, I don't know how they find these patients in the United States, where 40% of the patients had had prior adjuvant endocrine therapy and 60% had not. I don't see 60% patients in my practice with metastatic hormone receptor positive disease who have never seen hormonal therapy. But those are the patients that went into that study. But the point is that if you see such a patient in your practice, then this result totally applies to that patient. Then you can explain that to that patient and maybe offer dual therapy. Otherwise, sequential single therapy remains the standard. This trial was a randomized phase 2, was not supposed to look at survival, but they looked anyway when the trial was done, and presented at last San Antonio meeting that there's actually a survival advantage of fulvestrant over anastrozole in first-line setting. So should fulvestrant be our first-line standard for postmenopausal women? Probably not, until the definitive confirmed trial, and that is the name of the trial, is confirmed, is going to be reported within a year or so. So we should wait for that probably. And then, as I've discussed before, there's always crosstalk in these pathways. And the central element, mTOR, also comes into play in the hormonal signaling axis. So BOLERO-2 looked at the role of everolimus in addition to exemestane in patients who had failed non-steroidal AI. Anastrozole, letrozole are non-steroidal AIs, whereas exemestane is a steroidal irreversible inactivator of aromatase. So in this study, they were able to show a tremendous improvement in progression-free survival Overall survival was not statistically significantly different with further follow-up, but at least for progression-free survival, it was a huge enough difference that it led to FDA approval of the drug, but it has toxicities of stomatitis, fatigue, and rarely problematic fatal pneumonitis, which is rare but can happen. So the uptake has been somewhat slow to give this therapy. And the latest addition is CDK4/6 inhibitors, that actually block progression from G1 to S phase in the cell cycle. So it really puts a brake on the tumor. It's not a great tumor shrinking drug. It's a brake to the tumor growth. That's why progression-free survival is a far more robust endpoint for this type of drug than response rate, although it does alter response rate a little bit. So Richard Finn had presented it at AACR, but now it's published in Lancet, this astounding result that when you add palbociclib to letrozole, you get a doubling from 10 months to 20 months in progression-free survival. We were not used to seeing such huge delta in hormonal therapy trials, but this seems to be the new paradigm with newer targeted agents. The next trial was presented at ASCO, PALOMA-3, which was actually with fulvestrant. And again, palbociclib was added to fulvestrant compared to fulvestrant alone. And note that this is the higher robust dose of fulvestrant at 500, not the older, weaker dose of 250, which has been defeated by the higher dose in randomized trials. And this, again, showed a tremendous advantage going from less than 4 months to more than 9 months in PFS in the intent to treat population. When you looked at the smaller subset of patients that have confirmed central blinded audit by blinded, not blind radiologists, that median has not even been reached in this study. So should this become our standard now to offer fulvestrant with palbo? The truth is, in our office, we are now giving it like water. I don't know how Chuck Vogel gets it approved, but 90% of patients we have given it to are not FDA-label candidates for this therapy. But somehow, we get that. So it's given 3 weeks on, 1 week off, and neutropenia is the main toxicity, but it's not febrile neutropenia. So if you think about it, neutropenia becomes febrile neutropenia when there is associated mucositis with it to gain entry to the bacteria to the bloodstream. So because it doesn't cause mucositis, just neutropenia, the incidence of febrile neutropenia is very low, unlike what you would see with, let's say, Taxotere or doxorubicin, et cetera. So it's the kind of neutropenia you may be even better off not looking. Otherwise, it's a paper toxicity. It doesn't serve a purpose to read the toxicity to the patient who's not feeling it. So exemestane has also been combined with an HDAC inhibitor, etinostat, by my friend Denise Yardley. It has shown positive results, but they are too preliminary. But the good news is now we have things to add to hormonal therapy, from everolimus to CDK4/6 inhibitors to etinostat. And there are many CDK4/6 inhibitors, 7 of them in the pipeline. And the newer ones penetrate the blood-brain barrier very well. Abemaciclib has 100% penetration. So that bodes well for our patients. So now I'm just now about to be over time, but I'll quickly finish triple-negative disease in the next 5 to 6 minutes. So triple-negative disease is seen in 15% of patients, more commonly in African Americans, where it's up to 35–40% of patients. It's more aggressive. It mostly has basal-like signature, but not all basal-likes are triple-negative. Not all triple-negatives are basal-like. There's 75% overlap, and they share common characteristics with patients who are BRCA1 mutated. And that has led to a term, BRCA-ness, which has caught on. BRCA-ness is used for triple-negative tumors that are behaving as if they are BRCA positive in women who otherwise have no BRCA mutation. So it's good to know the term BRCA-ness to justify treating them differently. They are aggressive. They tend to relapse early after adjuvant therapy, and they result in shorter survival. Again, this is fine print of guidelines for triple-negative disease. I can just tell you the bottom line is there is no guideline. There is no gold standard. There's no single drug approved by FDA for triple-negative disease. So it's your guess And generally, based on trials, if somebody's behaving badly, you give them combination therapy. If their disease is not galloping away, you still can use sequential single agents. And soon you'll get to use second line and third line and fourth line in these patients because they keep giving you that opportunity sooner rather than later. There was a beautiful paper by Ingrid Mayer, which I urge all of you to read, which talks about the subsets of this disease. So to explain this simply, they have a test PAM50, which again is genotyping the tumor by intrinsic subtypes. And 80% of these cancers by their signature tend to be basal-like, but then there are HER2 patients in there. Remember, these are all HER2 negative patients by conventional testing. But by molecular testing, they have HER2 pathway turned on. Some are normal-like, some are luminal B, which is the worst behaving subset of hormone receptor positive patients. And luminal A is best behaving, strongly hormone-rich tumors. And again, these are ER/PR negative by conventional testing, but they are sliver of them in there. So there's complex heterogeneity at the molecular level that we don't understand. Hence, there must be epigenetic changes, changes that occur beyond the genes that make this tumor, for example, behave badly with the gene sending all the right signals of luminal A disease, but by the time it's malignant, it has no characteristics morphologically of hormone receptor positive disease. Another group took 14 databases, merged them, and subdivided into various subtypes. If I can recall, this is mesenchymal immunomodulatory, basal-like 2, basal-like 1, unclassified luminal androgen receptor, and mesenchymal stem-like. So when they applied this test to these subgroups, they saw even within those uniform molecular slivers, the two tests had some differences of opinion, where you can see that luminal androgen receptor subgroup right here, when subjected to PAM50, shows that 3/4 of these patients have HER2 activation at the molecular level. So now we are really getting deeper and deeper into understanding subgroups so that we can pick the right drugs, which bodes very well for our patients. So you can basically divide them up and see, where are we going to use platinums or PARP inhibitors, where to use androgen blockade, where we use EGFR inhibitors, where we use immunotherapy. So that's where the field is headed in triple-negative disease. Platinums were shown to be active, and it was seen that in BRCA mutated patients, the response rate doubles from 30% to about 55%. So people started thinking that everybody has to have platinum. And hats off to these British investigators who did the trial, who randomly assigned triple-negative patients to docetaxel or carboplatin just to see what happens. And they then also tested for BRCA1/2 mutations. So interestingly, there was no difference in progression-free survival between carboplatin and docetaxel, which, to some is disappointing. To me, it's very encouraging. I'm very anti-alopecia. So this shows you that carbo is every bit as good as docetaxel, so why use docetaxel in these patients? So to me, it's a very positive result. And when you looked at the subsets, BRCA2 mutated patients actually had twice the response rate to carboplatin. So the moral of the story is not all triple negatives deserve a platinum. They do if they don't want to lose their hair. But the benefit really is in BRCA mutated patients, not in the unmutated patients. And then there was something that was touted a lot by some groups of researchers, homologous repair deficiency score, saying that that's a measure of Burkitt, and those patients should get platinum. But in this trial, it did not pan out that those patients have any additional advantage of getting platinum over docetaxel. So that is another myth buster. Tenacity is a trial that's looking at, it's Celgene sponsored. It looks at their compound, albumin-bound paclitaxel with gemcitabine or with carboplatin or with no taxane in this arm. And the winner of these two could compete with gemcitabine carboplatin. And remember, this is the control arm because it had been popularized by Joyce O'Shaughnessy, which I'll show you in a moment, as the regimen to go to. So PARP inhibitor basically works by a mechanism better shown on this slide. The normal cells have two ways to repair DNA damage, by this enzyme PARP or by the BRCA pathway, if you give somebody a PARP inhibitor here, the normal cell can be repaired by the other mechanism, but in patients who have BRCA mutation and already have lost this mechanism, this PARP inhibitor would become lethal. So it's taking advantage of an Achilles heel in the tumor of a BRCA mutated patient. So it makes sense to give DNA damaging agents and PARP inhibitors to BRCA mutated patients. So Joyce O'Shaughnessy had popularized carboplatin gemcitabine, and this was a very famous and now infamous trial in the plenary session of ASCO one year, where she showed in a randomized phase 2, which is rare to enter plenary session. Generally, plenary sessions are reserved for game-changing, practice-changing abstracts of large randomized phase 3 trials. This was a phase 2 trial where BSI-201, a PARP inhibitor, which was later declared not too much of a PARP inhibitor, showed huge advantage when added to carboplatin gemcitabine. And interestingly, toxicities were less in the combination arm than not, as if it was part drug, part Neulasta, et cetera. But the phase 3 trial was completely stone cold negative. A whole sales force had been raised by a pharmaceutical company before the phase 3 results came. So of course, a lot of people lost their jobs. But a lesson was learned that one should not get too excited with phase 2 trials. A lesson we have learned one too many times in oncology. So this is really not a PARP inhibitor, as it turned out, in therapeutic doses. That was the press release from the company. In non-therapeutic doses, of course, everything is, even French fries in unusual doses can be lethal. But this had to be within therapeutic doses. A drug has to have the mechanism that's purported for it. So now there's a whole list of PARP inhibitors in the pipeline. Many of them are oral compounds, which is very good. Finally, couple of small things. Immunotherapy is on the horizon. It's far more advanced in melanoma and in lung cancer, but in breast cancer, it's only beginning. The concept is that tumors cannot develop until immune system fails. So there must be a friendly handshake going on between tumor cells and immune system cells saying, we are one of you, we are good guys, don't attack us. So these drugs actually take away that fake uniform and show the army that these are actually impersonators, kill them. So the receptor actually is on the lymphocytes, and the ligand is on tumor cells. That's why we test tumors for PD-L1 positivity, not for PD-1 positivity. So PD-L1 has that handshake going on with PD-1, and that downregulates the immune system and their activity and their killing ability. So two abstracts, one at AACR, one at San Antonio, have looked at two different drugs. This is pembrolizumab, Merck compound, which is in the market for melanoma, about to be approved for lung cancer, and this is the Genentech Roche compound, which is not approved yet. Both showed about 18-19% response rate. But if you look at degree of PD-L1 positivity, response rates change, but we don't have time to go into that. The last thing I would talk about is targeted therapy, why that hasn't worked. This was done by Fabrice André in France. He took 427 patients, 407 had biopsy material available. They were able to do genomics on nearly 300 and found 55 who could be candidates for genomic-driven treatment and 195 potentially druggable lesions, so to speak. And at the end of all this exercise, they had 4 responders. You start with more than 400 patients, you end up with only 4 responders with these targets such as PIK3CA, EGFR, AKT, FGFR, IGF. Overall benefit rate was 1%, response rate was 1%, overall benefit rate of 3%. So very disappointing so far, very far from lung cancer experience. So obviously a lot more work needs to be done because just finding a mutation doesn't mean it's the driver. It could be the passenger. This is deliberately busy to show you the flurry of activity of new drugs being tested for triple-negative disease. Everybody sees this as an opportunity. So when you have this many contenders, just like the presidential candidates, you know that there's no lead contender yet. But have we made progress? Obviously, compared to mid-90s to the turn of century to now, there's been consistent lifting of these curves. survival curves, where the median survival here was under 2 years only 20 years ago, and now I would venture to say, in this article published in 2007, it had already crossed the 2-year mark. If you drew these curves today, it'll be above 3 years, because we know that 20% of the population HER2 positives, it's already approaching 5 years. So this is all very, very encouraging. This is not depressing news. So breast cancer is heterogeneous. There's been tremendous progress. In HER2 positive disease, CDK4/6 inhibitors are the newest addition in the hormone receptor positive space. Triple negative breast cancer, now we know, is not single disease either, has many subtypes, and BRCA mutated tumors have a reason to be treated differently. Molecularly targeted therapies need a lot more research. Immunotherapy is promising, but we are now having innovative trial designs, which have adaptive designs like I-SPY, which is neoadjuvant, where we have the ability of writing one protocol and keep substituting drugs in it and retiring drugs from it that are not performing well to speed up the process of clinical trials. So there's a lot of hope for the future. Thank you very much for your attention.